Okay, everybody, Dr. Rafich from Vet Triage here. Let's see, we are continuing through this issue of Veterinary Surgery from May 2022. Today we're talking about equine. We've got an imaging study, ex vivo comparison of 3 Tesla MRI and multidetector CT arthrography to identify artificial soft tissue lesions in equine stifles. This study comes out of Zürich, Switzerland, university there. The objective is to determine the diagnostic performance of CT arthrography and 3 Tesla MRI for detecting artificial meniscotibial ligament, and cranial and cruciate ligament lesions in horses. Ex vivo study, so it's a cadaver study, 19 stifles. They created stab-like defects in the menisci, in the cruciate ligament, and in the meniscotibial ligament via arthroscopy before CTing and MRIing the stifles. For those who don't know, a 3 Tesla MRI, as far as I know, is the strongest magnet available clinically. There are stronger magnets they use for research purposes that become a bit dangerous for clinical use. But as far as clinical goes, a 3.0 Tesla MRI is the most powerful one. So they are using, as far as I know, again, the best in the market for MRIs. Results: the sensitivity and specificity of MRI, which was 41% and 86% respectively, and then the CT arthroscopy or arthrography, which is 32% and 90% sensitivity and specificity respectively, did not differ. The sensitivity MRI ranging from 24 to 50% and CT 19% to 40%, and the specificity MRI 75 to 92%, CT 75 to 100%. Did not differ when detecting lesions of the menisci, the meniscotibial ligament, and the cruciate ligament. The highest sensitivities were achieved when the meniscotibial ligaments were evaluated with MRI at 50% and cruciate ligament with both modalities at 40%. So the conclusion was the diagnostic performance of CT was comparable with MRI with a low to moderate sensitivity and a high specificity. Introduction. Meniscal lesions represent up to 68% of soft tissue lesions in the stifle, where cruciate ligament only account for 9%. Meniscal lesions vary in their severity and are graded from tears in the meniscus without significant separation, grade 1, over complete tears in the cranial pole of the meniscus, grade 2, severe tears of the meniscus which extend beneath the femoral condyle, grade 3. Partial or complete tearing of the cranial cruciate ligament most commonly occurs in the mid-body. Radiographs is useful for the diagnosis of soft tissue lesions in the stifle if there's mineralization of the soft tissue structures, or there's enthesiophyte formation, or there's avulsion fractures. Ultrasound can be used as well. Meniscal lesions have been identified more often by ultrasound than arthroscopy, but meniscotibial ligament and cruciate ligament lesions have been better detected with arthroscopy. Higher difference diagnosing meniscotibial tears by scoping than by ultrasound have been seen. Cruciate ligaments can only be poorly and partially visualized using ultrasound. It has therefore been recommended that basic imaging techniques such as ultrasound are used in conjunction with arthroscopy when diagnosing stifle pathologies. Scoping exploration can be used, needle arthroscopy can be used, and only a third of the menisci and cruciate ligaments can be visualized. In addition, examining the opposite articular cartilage is impaired. CT can be used in animals, and intra-articular contrast medium diffuses within the joint, outlining intra-articular soft tissue structures and articular cartilage. Then abnormalities in size, shape, and contours of intrasynovial tissues can be identified in humans suffering from claustrophobia and patients with subcutaneous defibrillators or other ferromagnetic implants where MRI is contraindicated. You can use a multidetector CT arthrography of the stifle instead. And in human knees, the CT route is effective for reporting diseases with a sensitivity and specificity of 98% and 94%, 90% and 96% respectively for meniscal and cranial cruciate ligament injuries. All right, materials and methods. They used warm blood and thoroughbred horses. They ranged in age from 5 to 22 years, different sexes. And then for the scoping, they use a 30-degree forward-angled 4 mm rigid scope. The medial compartment of the femoral tibial joint was explored, as was the lateral compartment. Then they created the stab injuries. They use a 3.0 MRI scanner. This is just an example picture of the artificial lesion they created in this horse. And then here's 2 more images of the scoping where they created lesions. If you want to pause the video there, you can. And then here we have some examples of the imaging. The CT scan they used was a multidetector 16-slice scanner with a slice thickness of 0.6 millimeters. For evaluating the imaging studies, a lesion was considered present in a meniscotibial ligament. 1, if synovial fluid or contrast medium was infiltrating with focal internal signal or contrast accumulation. 2, if with MRI, partial or complete truncation with loose fibers were noted. Or 3, with CT arthrography, abnormal or unclear margins were identified. For the menisci, a lesion was present if 1, synovial fluid or contrast medium was infiltrating with a linear or focal internal signal or contrast accumulation and or a meniscal fragment was seen. 2, abnormal margins were noted. And then for the cruciate ligament, synovial fluid contrast medium was infiltrating with focal internal signal and contrast accumulation, and an abnormal shape like marked focal thickening, bowed or undulating contours were noted. So for the results, the horses were a mean age of 14.2 years. In this imaging here, so with this figure 4, I'm just going to read what I underlined here. You can see a true positive lesion in the cranial meniscotibial ligament, which is the arrowhead. So you have the arrowhead here, and arrowhead is also here. And then the cranial horn of the lateral meniscus, which is the arrow. So arrow here, arrow here, arrow here. There is a clear linear infiltration of contrast medium and synovial fluid. Note the extravasation of contrast medium and synovial fluid, cranial and lateral to the femoral tibial joint. That's labeled by the X. So that X is right here. This is extravasation. And then over here. The long digital extensor tendon is marked by the asterisk, and so that's right here. Then in this imaging here, this shows a true positive lesion in the caudal cruciate ligament in a cadaver. With CT scan, the mid portion appears mildly hyperdense, and with MRI, an increased signal intensity with mild linear infiltration is seen. The sensitivity of MRI was similar at 41% compared to CT at 32%. Specificity values were comparable, MRI 86%, CT 90%, and the diagnostic performance of MRI and CT did not differ. For the different lesion groups, menisci, meniscotibial ligaments, and cruciate ligaments, true positive rates of both modalities were low to moderate. So MRI ranged from 24 to 50%, CT 19 to 40%, whereas true negative rates were good to excellent. MRI 75 to 92%, CT 75 to 100%. In general, MRI and CT were similar. Discussion. The diagnostic performance of CT for anterior cruciate ligament tears in humans is excellent. However, most studies do not differentiate between complete and partial tears. In dogs, CT has a high sensitivity, 96 to 100%, and specificity, 75 to 100% for cranial cruciate ligament lesions, both partial and complete tears. Detection rate of cranial meniscotibial ligament injuries was high with CT, whereas only 1 out of 3 cruciate ligament defects were identified in another study. If intrameniscal hyperintense signal breaching in the articular surface is seen on 2 slices with a 3 millimeter slice thickness, the positive predictive values were 94 to 96%. However, if this finding was present on a single slice only, the positive predictive value decreased to 18 to 43%. Studies in dogs have also shown low sensitivity at 45 to 90% for meniscal lesions as well as cranial cruciate ligament lesions in MRI. Likewise, CT reported sensitivity values of 13 to 73% and specificity values of 57 to 100% for meniscal lesions. In all soft tissue structures, the lesions may have collapsed due to lack of synovial fusion, impairing infiltration of synovial fluid or contrast medium. In contrast to clinical cases, lesions were rather small, and the reviewers could not take all CT and MRI criteria into account. The increased internal signal intensity of a ligament and menisci, the abnormal underlying bone or periligament changes and meniscal abnormalities, such as abnormal margins in shape, presence of adipose or fibrous tissue, or meniscal capsular dissociation could have helped detect lesions. In MRI, magic angle artifacts within the soft tissue structures may have obscured smaller lesions. In conclusion, the CT performed similar to MRI. The CT sensitivity was best for cruciate ligament lesions, which is important for equine clinicians, as you can't visualize this on basic imaging. CT was least sensitive for meniscal lesions. In these cases, adjunctive ultrasound could help for the meniscus. CT and MRI had high specificity, thus being highly accurate in diagnosing an intact soft tissue structure. This is an important result for the future of CT in clinical cases. For instance, when aiming at excluding certain soft tissue lesions within the stifle joint in horses without undergoing scoping, CT should be used in the preoperative diagnostic workup of stifles when ultrasound is not definitive or a cruciate ligament is suspected. So pretty solid study. You usually had larger numbers of stifles for this, but overall, it's a good start to something, especially if the equine world is going more towards high-end imaging, with imaging machines that are tailored for animals that are that large. Then it's a good move in the right direction. So, all right, guys, we'll see you in the next video. Thanks again.